Okay, so yeah, as I mentioned, I'm Tamsin. I'm a urgent care fellow. So I did my postgraduate training in New Zealand. You can probably hear from my accent. I'm British originally. So I did my training in the UK. Have done kind of various diplomas in New Zealand. But always had a passion for global health. Um, and I am very involved with Medic to Medic. And then after I graduated, I became more involved on the board, and then became CEO in 2014. So it's been, yeah, a little over 10 years now. Um, so this session, sort of, in order to give a bit of context about electives in Malawi, we kind of delve a little bit into the training, like medical education in Malawi, which leads on to medic, and then that leads on to the medical electives, which is maybe where there's a bit more interest in as well. So, yeah, the overall aim of this session is to understand some of the challenges facing students in training in low resource settings, and then to learn about some of the opportunities for electives in Malawi run by Medic to Medic. So this is the kind of only main discussion point of this session. And again, feel free to unmute yourself if you'd like to, but otherwise, yeah, feel free to pop in the chat box any thoughts you've got. But we start off with a discussion. So what challenges have you or your friends or colleagues had during your studies? And again, you don't need to share anything confidential, anything that you don't want to. It can be kind of in more general terms. Um, and if no one has any discussion points, I can share some of the common themes that have come up when we've been doing these sessions before. But I'll give everyone maybe 30 seconds to have a think and jot anything down in the chat box, if you've got any thoughts. So a lot of the common ones we get is like the double rent, so having to pay for rentals where your university is, and then if you're on placement in hospital, which is further away, and you have to find accommodation for either a short period of time because you're there for just a rotation block, or yeah, then you have to find accommodation and then pay for it on top of that. We've had a comment in the box here saying finding time between clinics and tutorials to study. Yeah, absolutely. Yeah, the clinical kind of placement requirements and then studying for exams on top is definitely one that comes up quite commonly. So yeah, thank you for contributing that. Um, yeah, and then as some people often say like moving away from home for the first time, kind of managing money, finances, can be a little bit overwhelming in amongst kind of studying and everything else that's going on. If anyone has any other thoughts, again, feel free to pop them in the box. But if we just flip that discussion slightly, so thinking about challenges that our student colleagues in resource limited context may face, are there any new challenges or new things that you think might be facing students kind of training as health workers in these regions? I'll give everyone a few seconds to maybe think of something. And again, it's okay if you're not sure or don't have much to contribute at this point. Um, so kind of we often find that it's all the same things moving away from home for the first time. Um, if, yeah, those study skills that you kind of develop over time, time commitments between clinical placements, and then like studying for exams, all of those things still apply. But you've also got electricity blackouts and infrastructural problems or challenges. So there'll be blackouts for maybe anywhere between 1 hour to 12 hours in a day. You can't afford laptops or study materials. The university libraries are often overstretched. Um, Sometimes there's fuel shortages, so actually transportation to placements is extremely difficult or extremely expensive. And then Wi-Fi and network challenges as well. So sometimes like the network will just cut off for a couple of hours, or it will be really challenging to get kind of messages and calls through, and getting data bundles for studying um, can be challenging at times as well. Um, so yeah, I've just seen a comment on the box. Yeah, Delgit, you're yeah, absolutely allowed to talk out loud as well. So if you want to unmute yourself and contribute something, yeah, feel free to do that. I'll try and see everyone who puts a comment on as we go. But yeah, if you want to raise your hand as well, and then unmute yourself, like that's fine. Whatever is more comfortable for you as we go through. Any other contributions before we move on from those discussions? Cool. Okay, so we'll just keep going.
Oh,
The
sorry, I just found the unmute button. My bad.
perfect.
Sorry, so yeah, I'm down. But my question was, um, when you were talking about resource limited places, I'm taking it that's places like you were talking about. So would one of the challenges be when you're working with a team that's already in a resource constraint, under a constraint, will they be like expecting you to contribute more than maybe you're capable of to the team dynamic?
Yeah, that's a really good point. Yep. So often students in training are used for service provision, and often that comes with sort of lack of supervision. If you haven't got the resources in the hospitals, you're actually exposed to a lot of morbidity and mortality, poor patient outcomes, which can be quite stressful and distressing to be part of as well. Um, so yeah, absolutely, that's a really great point, and that can often lead to kind of burnout, stress, mental health challenges as well. So yeah, they're all kind of linked into together, but that's a really great pickup. Thank you for contributing that. So we'll keep going, but yeah, as I say, feel free, um, yeah, to contribute at any time. Um, so this is the bit where I talk at you guys for a little bit. So just kind of sharing a bit about the context of Malawi. So Malawi is in southern Eastern Africa. It's kind of on the border of southern Africa and Eastern Africa, highlighted there on the map. It's got three seasons, so a cool, dry season, hot and dry, and then hot and wet, traditionally known as the rainy season. It's a quite long, thin country compared to other countries in Africa, and it's divided into three regions, southern, central, and northern. And it's got a population probably just above 19 million now, but at the last census it was estimated at 19 million. And its capital is Lilongwe, which is in the central region. But the commercial kind of business districts are generally in the southern region in Blantyre, and its currency is the Malawi kwacha. So if you're good at pub quizzes, I hope that comes up at some point for you guys. Um, this just gives a bit more information about kind of the economy of Malawi. So 80% of Malawi's population depends on agriculture, and that's generally in kind of the subsistence farming rather than a commercial farming sort of field. But because of that, because it's very dependent on agriculture, it's actually very vulnerable to climatic shocks. So probably a term we'll become a lot more familiar with over the next kind of decade and years to come is going to be climate injustice, which is essentially a term used to define the countries that are going to be most affected by climate change, but have actually contributed very little in terms of carbon emissions per capita. Um, so it's yeah one of the top three countries to be affected by climate change. And it is one of the only countries in Africa to have never had a civil war. So a very peaceful country. And the gross national income is around 633 US dollars per year. And just some figures from 2023. So this was during Cyclone Freddy, which happened in March at the end of the rainy season, um, which was the longest and strongest tropical cyclone ever recorded. Lasted over a month, and Malawi was the country that was most severely affected. So there were a lot of flooding, a lot of mudslides, a lot of people were killed. Unfortunately, one of the medic team was killed with her daughter in one of the mudslides. But it essentially led to a lot of food insecurity because of a lot of agricultural land was destroyed through the mudslides and the flooding, which resulted in food inflation um, rising to above a third, and then inflation generally rose by a third, and that's all the while salaries for the majority of the population stayed the same. There wasn't that increase in salaries to account for that. Um, the graph on the right, I sometimes get a little bit tongue-tied trying to explain it, but essentially, um, the line there defines the international poverty line. So it's kind of changed over the years. You've got the years along the bottom, and sort of the bit on the y-axis is the percentage of the Malawian population who earn less than the international poverty line. So in 2019, unfortunately, I haven't got any more up-to-date figures. 72%, or sorry, 70% of Malawi's population earned less than the international poverty line. And it's estimated that 72% of Malawi's population earn less than the gross national income. So there's a huge amount of poverty within Malawi. Um, I always like just kind of giving an overview about headlines when I'm doing these talks because I think it does show kind of different priorities and it kind of gives an overview of what's going on. So these are some news articles from today from Times Malawi. So there's a general election coming up in about 4 weeks' time. So there's a lot of political campaigning going on. So the first article is with the current president, Dr. Lazarus Chakwera, who's doing some political campaigning. The next one is talking about one of the district health officers is was doing a sensitization campaign at one of the local schools and trying to encourage girls to delay marriage and delay pregnancies. And then the final one was regarding sort of trying to do peaceful political campaigning and sort of peaceful response over the general elections. There are always a little bit of uh, unrest slash unease around political elections. Um, and I think I'm not sure how this year will go. So yeah, it will be interesting to see how things kind of play out. And then kind of looking at some health statistics for Malawi. So we've got Malawi's health statistics on the left, and then we've compared them with New Zealand's health statistics on the right. So you can see life expectancy very different. So for men, it's 62 um, in Malawi, and for New Zealand, estimated life expectancy is 80. Again, for females, 68 compared to 83 and a half. And if you look at kind of infant and under five, sorry, mortality, maternal mortality, like the statistics are kind of very notably different, with sort of 29 per thousand deaths for infants compared to 4 per thousand deaths in New Zealand. And then kind of looking at that in terms of your human resources for health. Again, you've got sort of less than zero point 0.1 doctors per thousand patients compared to 3.4 per thousand patients in New Zealand. And again, very similar statistics with nurse midwives as well. And I don't think this will be a surprise for us, but obviously, if you haven't got the health workforce available, then it's going to directly impact on the services that you can provide. So, the WHO say that your health workforce are one of the six building blocks of an effective, functioning health system, along with kind of all those other things that you see listed, but they are directly related to services that can be provided. So the WHO estimate there should be 240 professionals per 100,000 people. Sorry, I'll go back to that graph. So the kind of world map here shows that the areas with greater density of doctors compared to kind of the very light yellow where there's fewer doctors for the population. So you can see that kind of sub-Saharan Africa, Southeast Asia, not as high doctor densities compared to kind of Europe, US, Australasia. And then if you look at those numbers kind of more specifically, so Australia, 240 doctors per 100,000, you kind of work your way down middle income countries and then get to Malawi, where it's estimated at 5 doctors per 100,000 people. Um, and again, I put this graph in for sort of completeness, but it's kind of already been discussed that This is looking at a patient outcome, so looking at maternal mortality and the relationship to the number of medical doctors per thousand people. So the higher the maternal mortality, so a few countries are highlighted here. So Malawi, Zambia, Uganda are the ones that are highlighted. Has a very high maternal mortality and very few medical doctors per thousand, compared to kind of Australia, UK, US. The maternal mortality is not as high, and they've got um, a higher number of doctors. So definitely kind of an inverse relationship there. So again, the WHO estimate that there's a shortfall of 10 million health workers by 2030, and most of those are in low and middle income countries. And that Africa alone needs an estimated 1.5 million more healthcare workers in order to provide just basic services. And kind of looking at that in a kind of a bit more global distribution of disease, it's estimated that the Americas have 10% of the global burden of disease. Yeah, almost 37% of the world's health workers. Sub-Saharan Africa has almost a quarter of the global disease burden, but only 3% of the world's health workers and less than 1% of the world's financial resources. So when we talk about kind of inequity amongst healthcare, there's huge levels of inequity globally. So there is a critical shortage of health workers. Um, so looking at what some of the reasons might there be, again, you feel free to unmute yourself or jot anything down in the chat box. If you've got any ideas, some of those graphics might give a few hints at what some possible kind of discussion points are. I'll just give everyone a few seconds if you've got any ideas or want to contribute anything. It's a good break point um to make sure everyone's still with us. Any ideas? So I'll start everyone off, or actually the graphics just have given it all away. But yeah, so there's migration, sort of traditionally termed sort of the brain drain. Um, so that can be both internal, so to a better paid job, so either in the private sector, or to an NGO. And I think that's where NGOs actually, it's a really difficult balance. For NGOs within low resource contexts because actually you want to pay your workers a living wage, and often that means that's higher than the government wages, but actually in doing so you're removing people from the government health system, and actually in order to drive change sort of within the government health system, you could argue that actually it slows down change because you haven't got health workers there who can advocate and sort of make changes. Obviously, there's different perspectives to that, and it's a very kind of simplistic view which we've just given. But there's, yeah, migration internally within a country to a better job to the private sector, or actually they go outside and, yeah, traditionally termed the brain drain, where you've got very highly skilled health workers going to high income nations to fill service gaps. Um, Traditionally, as well, so thinking back to the start of the HIV epidemic, a lot of health workers did become infected with HIV through sort of needle stick injuries or body fluid exposure. Um, then when was the Ebola epidemic? Like about 10 years ago. So yeah, 10 years ago we saw that with Ebola as well, and most recently with COVID. Like health workers are traditionally more exposed to infectious diseases, which carries a risk of morbidity, mortality. So one of the other reasons why there may be fewer health workers in those regions. But also something that people don't often kind of think about is that actually um, there aren't enough being trained to sustain the needs of the population. So looking at the training of doctors, it's just kind of a few sort of numbers to think about. So Ethiopia produces 200 doctors per year for 75 million people. New Zealand produces approximately 600 doctors per year for 5 million people. Two-thirds of sub-Saharan African countries have only one medical school, while some still don't have any. So actually, those countries in those regions have to rely on the brain drain from other countries in order to have doctors. in their regions. And a bit of work was done on the brain drain a few years ago. It is out of date now, but I'm not sure too much has changed. But it was estimated that the total number of African-born doctors and nurses working overseas accounts for less than 12% of the estimated shortages. So, whilst obviously it would still be fantastic to boost your workforce by over 12%, it's not, the brain drain is not the only reason related to the shortages of health workers in Africa. So we'll go back to talking about Malawi again. So the training of doctors in Malawi, prior to independence in 1963, students were sent under scholarships to train in the UK. And that led to a coined term in global health that there were more Malawian doctors in Manchester in the UK than the entire country of Malawi. So it sort of just showed that actually, if you send your brightest and youngest minds away during their formative years, they're very unlikely to return. So, um, in order to rectify that situation, a medical school was set up in the early 90s. Initially, students were still sent to do their preclinical studies in the UK, and then they came back to Malawi for their clinical part of their training. So initially it was just an institution of 12 students, but now it's a university with over 1,500 students in training, and that's a combination of medics, nurse midwives, postgraduate training, medical laboratory science, physiotherapy, pharmacy. It trains a whole range of health workers. So currently, students still do three preclinical years, and that's done in Blantyre, where the university is based. And then they do a further three clinical years of study, and that's spread between the two main cities, Lilongwe and Blantyre. And then once they're done, pretty similarly to other countries, they're required to undergo an internship. And that generally lasts for about 18 months to 2 years, depending on the rotations and whether they pass the requirements for that rotation. And there's always a suggestion that as interns, they may or may not be paid, because when the government runs out of money, they try to use the argument that the doctors are not yet fully registered with the Malawi Medical Council. Therefore, the internship is still part of their training, so um, they don't need to pay them. That happened a few years ago, and that's despite interns doing sort of 1 in 3 24-hour on-calls, doing cesarean sections by themselves overnight. Fortunately, at the moment, they are being paid, but they are the only health worker on internships that are being paid. So basically, every health worker in Malawi, whether you're kind of a clinical officer, a pharmacist, physio, you all do an internship, and those interns who are not doctors, they get what's called a stipend, which is doesn't pay very much at all. It's about kind of 60 New Zealand dollars a month during their internship. So there's still many struggles for those graduates. So the health system in Malawi is composed of um, various different stakeholders. There's the government health system, and then it's supplemented by the missionary health system, which is called CHAM, and it refers to the Christian Health Association of Malawi. And if you find that a lot of missionary hospitals, CHAM hospitals, they're in very rural regions, and they often have a training institution attached to them. Um, so for CHAM hospitals, there is a fee-paying component for each sort of patient user. Under five, healthcare is fully subsidised by the government, as is antenatal and sort of midwifery care. But for most other patients, there is a service fee component related to it. So a lot of CHAM colleges will, part of the training that they will do is that they'll train clinical officers. Probably the nearest sort of similar profession within kind of high income nations would be sort of a nurse practitioner or physician associate. So their training is shorter, it's 3 years. Um, and they generally provide medical services that a doctor would provide, but in the rural areas. So there's a bit of task shifting. So things that would traditionally be seen in high income nations as a medical or doctor role, they're actually performed by clinical officers in the rural regions. And these are still very very proficient, very very qualified medical practitioners, but it's a way of sort of supplementing the healthcare system. So the majority of clinical officers are trained at another university in Lilongwe called the College of Health Sciences. So just going to share a little bit about challenges for students in training in Malawi. We kind of touched on a few things earlier at the start of our discussion, but I've just kind of highlighted some of the text messages that we've had or WhatsApp messages that we've had over the last few years. So the first message on the left essentially is a student saying that they're really struggling and that they haven't had anything to eat. So he says, "Today is my second day going without eating, and I don't have hopes to have a meal. Please kindly help me. I'm really stuck, and I have cumulative balances with my friends. Surviving on daily meals in the long way is not a joke now, and I'm really starving. That's why I have to write to you." So if we look at kind of at this point, fees have changed recently, but when this message was sent to us, tuition fees at this college were 550,000 kwacha per year, which at the time equated to 366 US dollars. And if we think back to the gross national income of 633 US dollars, and actually that 70% of the population earn less than that, actually, if you want to continue with education, go to college, the odds are completely stacked against you if you're from a poor family. Like your ability to kind of go forward and progress with education is really it's really stacked against you. The second message is just regarding this was a student who unfortunately was academically withdrawn from his studies. This was in his final year of MBBS, and we were trying to help him kind of navigate that. And he'd said essentially that he was struggling, that I feel like things are not going to work out and I'll remain like this forever. Sometimes I feel like I have nothing to offer in my life or in this world, and going back home, that means the end. But now I still think that things are not going to work out either. I'm fine physically, but in my mind, a lot of things are happening. So we also kind of see that actually when you're the first in your family to go further with school, further with education, actually you become your family's lifeline, and they place all your hopes on you because you're going to be the one that then gets a professional salary that's going to lift them out of sort of the subsistence farming um, uh, employment, that you're going to be able to help provide school fees for younger siblings. And so when that journey doesn't work out, actually, there's a lot of kind of guilt, feelings of failure. You've already spent and sacrificed so much money to get where you are, and to come out with nothing. It's a really big problem, and that's in amongst kind of all the equipment challenges, electricity and blackouts, network failures, fuel crisis, transport challenges as well. There's always lots of things going on. So if you do come from a poor family, like what are your options if you want to continue with education? So there is a government loan available, but unfortunately, there isn't enough of a government loan to go around to everyone. So if you get picked for one year, you won't necessarily get it the next year. And actually, you still have to pay it back once you're done. And the loans are at very, very high interest rates. So I used to really judge the government for putting really high interest rates. I didn't really understand it, but actually, I sort of understand it a bit more now because there's currency devaluations in Malawi maybe like every 12 to 18 months, and the devaluation is often 30 or 40%. So actually, if you're a government and you're wanting to preserve like your investment, so that you can support students coming after, actually you need to put a high interest rate on it because the currency is going to devalue. So it's really challenging, but essentially students don't like relying on that because it's unpredictable. You'll get it one year, you won't get it the next, and you have to pay it back at very high interest rates, which are still pretty unaffordable with all the other financial commitments that you'll then provide for your family. So it's not uncommon for students to sell family land, sell all their possessions, that we often hear about that. And I'm definitely not saying this happens a lot, but it's definitely not unheard of that when you've sold everything that you have and you still haven't got enough for what you need, um, it, some students do resort to selling themselves, and then that obviously exposes students to HIV, STIs, pregnancy, sexual violence, all of which come with its own challenges sort of after that. So this is where I tell you a little bit about Medic to Medic, which kind of comes onto the electives as well. So we're a charity. We're registered in the UK, in New Zealand, and in Malawi as well, and we support a range of health workers. So the only criteria really is that you have to be a health worker in training, and so you could be a doctor, dentist, physio, pharmacist, nurse midwife, clinical officers. Our new programs have included optometrists, audiologists, mental health workers, and it's a collaboration in Malawi with 12 universities. And essentially, we aim to support disadvantaged students, and we have a very loose kind of criteria for that, in that students are either from an orphan or single parent family or from a subsistence farming family where there's no sort of professional income or employment. They're from a rural area. So we're trying to increase access to medical education and professional employment by supporting the most vulnerable students who are at risk of dropping out of their training due to their backgrounds. So a scholarship, we guarantee their tuition fees until they've graduated. We give a once a semester allowance, which covers sort of stationery and living costs. And then we provide a medical equipment pack, medical textbooks, and also, if we've got the funding to do so, a laptop as well. So this was a picture taken of one of our students. This was during COVID when we had to convert to a lot of online sort of student selection and interviews. And this student was shortlisted by her college as very needy, very vulnerable. She was on the verge of dropping out. And we had our online interview. It wasn't with cameras because the network was really bad. So I just asked her to send us a picture of herself so that we could kind of put it with her file so that we knew who we were supporting, and she sent us this picture. And I really feel that like this picture just demonstrates like a lot of emotions in that. Like I feel like she's looking away from the camera. She's I feel like you can just see the weight of the world on her shoulders. She looks kind of stressed, withdrawn. Um, and yeah, so this student, she's an orphan, she's the oldest of her siblings, and she's trying to support the younger siblings through secondary school. They'd sold their land, but they still didn't have enough, and they were really struggling. And then we met her last year, and that's her now. And I think you can just pictorially really able to grasp kind of the impact that a scholarship has really had for her. Like she's engaging, she's looking at the camera, she's smiling, she's a lot more happy than she was before and a lot less stressed. So she's graduated now, which is awesome to be part of her journey. So we try and collect quotes as well to demonstrate to people kind of the impact of support. So this was one of the quotes we collected. So this student said, "I'm really a changed person since Medic to Medic rescued me. I'm more focused on my studies since I maximally use my time for my schoolwork. Before I could spend a lot of time finding ways to get money on my own to support myself." So we often find that students who need to pay tuition fees, they often skip classes because they're trying to earn money to pay, and then if they're not in classes, they're more likely to fail their exams, and then they need a repeat, and then they have to pay for the repeat. So it's just a vicious cycle. So actually, if we can provide scholarships, it really kind of helps students focus on their studies as well. So we often get questions from donors a little bit about sort of the brain drain. How many of our graduates actually stay in Malawi? So we try and answer that quite robustly, and we do a survey every 18 to 24 months. It gets increasingly chaotic as our community gets bigger, trying to trace everyone up. But last year, when we did our survey, um, we we can say robustly that 91% of our graduates are working in Malawi, 96% remain in Africa, and then there's just a minority that are overseas. And generally that's to do postgraduate studies. So there are postgraduate programs that Malawi doesn't do, like neurology, neurosurgery. There's several specialties that um, graduates have to go outside for their training, with the idea that they will come back. So that's why we kind of repeat these surveys to find out where everybody is. And again, in Malawi as well. So we do have a few graduates in Uganda, kind of a much smaller community, and we've got a few students in Zambia as well. But the majority of our community is in Malawi. And this was during COVID pandemic. It was an article on BBC Africa, and then the photo popped up, and I was like, I know that guy. So Dr. Francis is one of our graduates. So it was just quite fun to see that on social media. So about our elective program. So basically, our elective program is our way of helping us fundraise sustainably for our community in Malawi. So not for profit. The the fundraising that we get from the elective program goes straight back to student scholarships. So we've got a partnership with 6 hospitals. We're working on one more partnership at the moment, and then that will probably be enough for us to manage. But currently, we've got partnerships with 2 government hospitals, so a central tertiary hospital and then a district hospital. We've got 3 partnerships with CHAM hospitals, in a rural setting, urban setting, and then on Lakoma Island in the middle of Lake Malawi. And then we've got a partnership with a private hospital. So we tried to select locations that give a range of experiences, and each of those locations is a little bit different in terms of what they offer, and what experiences you'll have. And so we try and have a meeting with any elective students that are interested in coming, um, and doing an elective with us, so that we can work out what your goals are, what you're most interested in, and we can try and kind of guide you to say like, oh, this location would probably fit your goals, etc. Our alumni provide mentorship on the ground, so there's sort of your source of local knowledge if you've got questions about where to get a bus from, or actually the hospital isn't quite what you're expected, or you've got a bit of an issue with accommodation. Like they're your go-to if you need anything on the ground. We do some pre-departure stuff with all of our students as well. So we do some local language lessons. And that's where our students in Malawi will be your tutors. And the aim of the Chichewa lessons is it was more to teach you Chichewa, but actually, what we found is that the students giving the lessons get so much from it as well, and their leadership skills and their that they really flourish and kind of grow in confidence. So you find that like the first couple of lessons they're a little bit shy and nervous, but actually they by the end of it they've really enjoyed it. They've really developed their kind of presentation skills. So that's sort of part of it as well, as that your students are teaching students. We do some tropical medicine tutorials, and we do them via Zoom. And again, that's done by our graduate community in Malawi, and we have a structured program. Um, we are aiming at some stage in the future to do sort of a 2 to 3 day teaching, like when you arrive in country, and then kind of taking you to your elective location. So you have a bit more, I guess, bedside structured teaching over kind of tropical medicine topics. So that's in the pipeline. I can't promise that will be ready by the time kind of electives, your elective may happen, but that's what we're sort of aiming for. So it gives it a bit more of a structured preparation when you kind of arrive as well. There's also kind of opportunities for elective projects, and I'll talk a bit more about them in the next couple of slides. And then we try and do a webinar once a year, with elective students either presenting a poster or doing a short presentation. And the idea of that is that future elective students can come and listen, but it's also for kind of hospitals and stakeholders to listen to the projects that have been carried out and do some information sharing. And then you get a certificate to put on your CV that you've presented at an international online webinar event. So it kind of helps like with those CV building skills as well. And then we also do a debriefing session on return. So you'll definitely see things in Malawi that are different, that will maybe surprise you or shock you, or you may be involved in a particular patient case that has been a bit traumatizing, either because of the patient condition or the circumstances. And I know from my own personal experience, I find that actually the reverse culture shock going back to a high income nation from like living in a low resource setting for a while can be quite jarring. And so actually having that debriefing support is there. And you're all encouraged to have one session, but if you need more, then that can be arranged as well. So our elective locations, we've got 6 hospitals at the moment, but we are working on one more. So we've got Lacoma Island up here, which is a CHAM hospital. It's actually closest to Mozambique, but it's Malawian owned. But there are a lot of Mozambican patients that go to the hospital for treatment. There are no doctors here. It's run by well-trained clinical officers, and it's very much sort of an island experience as opposed to a Malawi experience. And the students that have been there before absolutely love it. It's definitely kind of a tropical island paradise. But I sort of explain to students there's Malawi time where things you can't rush Malawi. She'll work in at her own pace. Um, but then there's sort of for Lacoma, there's island time on top of that. So things don't always happen quickly, but it's a beautiful area, and we've worked doing like several projects again, which I'll talk about shortly on the island, which has been a lot easier to instigate because it's a small island community. Then we've got a CHAM hospital, St John's in Mzuzu. And the hospital we're working with in Mzuzu is the central hospital. So hopefully we'll have another central hospital as an option. And in northern Malawi, you can do safaris to Nika Plateau. You've got the lake very close. Nakata Bay is sort of a tourist spot for the lake, so it's quite well connected. And Mzuzu is a city, so there's lodges, supermarkets, more amenities available there. St John's has a college where we sponsor students, and so past students have got really involved with teaching first years, things like examination skills, non-communicable diseases, and kind of just basic history taking for the first years. So if you're interested in teaching, like there's other opportunities at St John's Hospital as well. And then moving down, we've got Zomba Central Hospital. So we have quite a few interns at Zomba. Quite a few of our mentors are based in Zomba. If you're sort of gunning for pathology and being busy, like Zomba is the place to go. It gets lots of referrals from district and sort of missionary hospitals, and it's got a heavy patient load. So expect to be a lot busier there. Mwanza is our district hospital. So again, on the border of Mozambique, there's quite a few Mozambican patients that come. And there's a prison locally where they do a clinic. There's teaching of health surveillance assistance. It is a very busy hospital because it's in the districts. So they get a lot of referrals from health centres. And they don't have any other elective students. So they're actually really engaged to work with us. And so it's got 3 doctors there, then it's staffed by clinical officers. And one of the doctors is one of our graduates as well. So we have a good relationship with them. And that's students that have been there before. We had one student that split his elective into multiple hospitals, and he said actually Mwanza was the most interesting because actually there were so many patients, a lot of pathology, and they could really get involved in kind of lots of different things. In Blantyre, we've got the private hospital. So Maiwatu, it tends to be a little bit more of an observership. So for some people, depending on the time of year you do your electives, like it's a good one to start with to kind of get orientated, not as fast paced as Zomba or Mwanza. Got more doctors around, is sort of more supported. So we'd kind of recommend doing that with another hospital as well, so you get a good flavour of sort of opportunities within Malawi. And then our final one is right at the tip of the bottom of Malawi. So it's Nsanje, which is a region in an area in the southern region, and it's at a hospital called Trinity, and it's got a college attached to it, so Trinity College, which is where we sponsor students as well. So again, opportunities to get involved in teaching. It is a very rural hospital, so it's if you want to see what it's like for the majority of Malawi's population, like Trinity is the one to go to. It is very well connected by road to Blantyre, so it's about 2.5 hours to Blantyre, so you can kind of get to weekend trips away and things like that. So these are a little bit about of our projects that we've done with students over the last couple of years. And some of these projects do require a little bit of additional fundraising to kind of manage that. But um, we can talk about those things a little bit on a more specific basis if you decide to go ahead on an elective with us. Um, so we had 14 elective students out of the 20 we've had that have done sort of elective student projects. Again, they're not compulsory, but it's just something we encourage it because there will be times that are quieter during your elective, and if it gives you sort of a bit more structure during your time at the hospital and something to do, and then to feed back to the hospital as well, then it can be really helpful at just building and maintaining those relationships with the partner hospitals. Um, so things that have been done in the past, we've done an audit of hospital facilities at Mwanza District Hospital, and that's kind of was a bit more of an information gathering exercise, so we can sort of do more evidence-based sort of interventions and projects for future students. On Lacoma Island, we've done quite a few things. So we've got a student there at the moment who's fundraised to put together 50 mother and baby packs for women on the maternity unit. Um, We've done some work in Nandala village. So we're building a house for health workers at their health centre. The health centre is currently not functional, and part of that reason is because health workers don't have any accommodation. So some students fundraise to build a house, so that's in progress at the moment. We've done some asthma management boxes. Asthma is really difficult to manage here because inhalers are so expensive. So we tried to establish some donations from medical aid abroad in Auckland of sort of nebules as well as inhalers, and we put together some guidelines for the clinical officers and management to use for asthma patients. Again, done some rebuilding in Nandala village. Nandala was a village that was really affected by Cyclone Freddy. 25% of their village died overnight. So there's still a lot of destruction. They're still sort of in their recovery phase. So we're trying to support them as much as we can. We've done some period poverty kits again on Lacoma Island, and then providing mosquito nets to boarding schools which don't have access to nets to as a malaria prevention. And we've got other things in the pipeline as well, and they're all a little bit dependent on sort of location and the idea is hopefully we'll be able to do some audits that go through all the hospitals and do sort of a case comparison of sort of PPH or maternity complications, and kind of analyze them at all of our hospital locations. And then hopefully the ambition is that we would get that written up and published in the Malawi Medical Journal. And again, that would give all of the elective students a name on a publication as kind of part of the data collection. But all, as I say, like Malawi, you can't rush Malawi, and there's definitely a process that we need to follow for that. So I can't make any promises, but those are our ambitions that we try and get done. The other thing we've done with elective students is that we've gone into schools and done some first aid demonstrations. So our Malawian students accompany the elective students, and they do a motivational talk to secondary school students, and it's basically to give students role models and to share sort of the challenges that they had at secondary school and how they overcame them, and yeah, try to motivate them to continue with education. There tends to be high dropout rates as you go through schools, mainly because you have to pay tuition fees for secondary school, which again, if you're from a poor family, is very challenging. So sharing kind of those challenges between their peers, we're hoping that we kind of can encourage students to stay at school and then consider a health related career. And the first aid demonstrations, they tend to be teaching CPR, doing the recovery position, management of choking, just kind of those three basic things to sort of encourage with learning. Um, We do try and so for all the students that come to the southern region, we do a visit to Nandala village, which is the village we've been working very closely with since Cyclone Freddy, and we sort of use that as a way for the village to do some income generating activities. So we pay a host family a fee for every student that they host. And then that goes into a village fund, and a committee decides how to spend it. And then it gives the elective students an opportunity to sort of see what village life is like. And you learn how to cook local foods, play board games, the local board games, and kind of get involved in village life as well. We are obviously encouraging you to come and get on an international flight, and for some of us that would be quite a long way. So we try and do carbon offsetting as well. Particularly like Malawi does have huge rates of deforestation for charcoal burning, as sort of electricity supply is really unpredictable. So charcoal is sort of the main source of energy for cooking. So we work with two community groups, one up north and then one in the southern region, to plant 200 trees per student that comes. And if you come during the rainy season, we're hoping we can kind of facilitate that if you wanted to, you can get involved in kind of those tree planting activities as well. And then the community groups give us a report at the end of the year, let us know how many trees have survived as well. Um, so essentially, the idea of the electives is that once we've paid for your expenses, we have enough Malawi kwacha left over that we can provide one student in Malawi with a scholarship for 1 year. So essentially, the more elective students that come to Malawi with us, we can then provide more scholarships to Malawian students locally. So it's part of our sort of sustainable fundraising strategy. So it really helps us for the future. Next year, we've got our marathon event. So we did this for the first time this year, and it went relatively well. So we're going to repeat it again this year. So if you have an elective over May, then I definitely need helpers to kind of help with the running of it, whether that's sort of running a water station or helping kind of in the medical tent, would be awesome. Or you can also like run a race as well. These are some pictures from our elective students over the last couple of years. Yeah, doing some first aid demonstrations. Yeah, carrying out some of their projects and being at school. Um, and in terms of fees, so for New Zealanders, we Medic to Medic has the overseas donee registration, which essentially means we can give you a tax deductible receipt, where you get a third of your donation back. So you've got 4 years to make the claim to the IRD. So by the time you've started working, after about 6 to 8 months, you can submit it to the IRD, and then you get a third of your donation fee back. So some of the fees might seem a little bit expensive, but kind of know that you do get a third of it back by the end. Well, within a kind of 12 to 18 months or so, depending on when you come. And in terms of the fees, so covers your airport pickup and drop off. We transport you to your elective location. We pay for the accommodation and your breakfast. We do your registration with the Malawi Medical Council. We do all your pre-departure stuff, so the language lessons, the tropical medicine tutorials, your hospital hosting fee, your elective mentorship. We do the carbon offsetting. We give you a guidebook, an Oxford handbook, and then a clinical medicine handbook. And we give you a local SIM card and do your first data bundle, which normally is enough to carry you through your entire elective. But if for whatever reason you use a lot of data or you need more top ups, then just logistically it's hard for us to do that. So we ask you to do that yourself. It doesn't include your airfares, doesn't include any pre-travel vaccination stuff that you need. It doesn't include kind of lunch, dinner, sightseeing trips. Or it doesn't include your indemnity insurance. That's normally free for students, but it might vary from country to country, and obviously your own travel insurance as well. Currently, I suspect this will change post general election, but currently Malawi has waived visa fees in an effort to kind of encourage tourists to come to Malawi. So at the moment, that there is no cost for that. When it was previously a cost, it was in the region of $50 to $100, kind of depending on what your travel plans were. But yeah, at the moment, that's waived. And then we do ask you if you have space in your luggage when you go back to New Zealand to help us just with transporting a few scrub tops. So we have a scrub top initiative where we make um, scrub tops out of African chitenge that we try and sell to emergency departments for Fun Shirt Friday. So we always need some help in transporting those. Um, and then we've got some other initiatives. And again, if anyone's interested in those, I know I've been talking for a long while, so I'll probably just skip these. But if you're interested in any of that, just drop me a message, and I can kind of give a bit more information. The final thing is just one video. It's about 3 minutes long, I think, and then we are done. So well done for persevering. I will hit play, and then we're almost there. Imagine a health worker.
Simple, isn't it?
Isn't it?
Let's imagine she's.
Or she's.
Imagine she's a he.
Let's stick with a her. What we call her Flo?
Florence.
Flo.
The thing is, whatever a health worker looks like, whatever she's called, imagine this. She saves lives every single day.
She's amazing.
But like many of us, she dreams of more.
Imagine that dream takes her to the big city.
You don't have to imagine that. This is what happens, time and time again. She might get a job at a private clinic. Or maybe she moves abroad to chase her dream.
Look, here she is in London.
She's working in a hospital.
Now imagine what's happened to us.
The people she left behind.
My wife died when she gave birth with no health worker to help her. Nobody in our village gets vaccinated.
Our children are dying from pneumonia and diarrhea.
We don't know how to protect ourselves from HIV and malaria. It will only take one health worker to show us. There are 2,000 people in our community, yet we don't have a single health worker.
Where is the health worker? Where is she?
It's hard to imagine 1 billion people.
It's harder still to imagine 1 billion people without a health worker.
Okay, cheer up. Imagine this.
Imagine she stays. What would it take to make her stay?
Imagine investing in her. Imagine paying her a living wage.
Imagine giving her quality training that she can pass on. And imagine giving her the proper tools for the job.
Now she's got support.
She feels safe. She's also got the respect of the people around her.
We listen to her and we learn.
She is important to us and we value her.
Imagine what would happen then.
Over the years, she could save hundreds of lives.
She could inspire and train hundreds of others to become health workers like her.
I could be one of them.
So could I.
Each of us could be saving lives in our own communities.
Imagine
that. And then imagine what happens next. And then?
And then a health worker for everyone, everywhere. Imagine that.
Now help us make it happen. Okay, so that video was from the Global Health Workforce Alliance, but covers sort of a lot of the things that we've already touched on. So that's the end of this presentation for today. Thanks so much for sticking with it. Seems I talk longer than I expect I will. So feel free to kind of reach out to me over WhatsApp. It does tend to be the easiest way to reach me when I'm kind of on the move. My WhatsApp does get pretty busy, so if you don't hear from me immediately, don't worry, I will get back in contact with you. And you can also check out our website. It's got a few more bits of information. It's got an elective section as well, and you can download our information leaflets. Also happy to send them to you over email as well. But otherwise, that's it for today. And if you've got any questions, again, feel free to pop them in the chat or unmute yourself. I will just stop the recording, and then we can do questions.